Venetoclax with obinutuzumab, CLL. Indication: chronic lymphocytic leukemia, CLL. First-line treatment of patients with previously untreated CLL. Previously untreated CLL with 17p deletion or TP53 mutation. Previously untreated CLL which does not have a 17p deletion or a TP53 mutation and when chemotherapy with FCR or BR is unsuitable. Previously untreated CLL which does not have a 17p deletion or a TP53 mutation and when chemotherapy with FCR or BR is suitable. Treatment intention: induction and maintenance of remission. Pre-assessment: record stage of disease, CT scan, neck, chest, abdomen and pelvis, presence or absence of B symptoms, cytopenias, clinical extent of disease, consider bone marrow aspirate and trophine. Blood tests: FBC, ESR, DT, UNES, LDH, G6PD, urate, calcium, magnesium, creatinine, phosphate, LFTs, glucose, IgS, beta-2 microglobulin. Hepatitis B core antibody and hepatitis B surface antigen AG, hepatitis C antibody, EBV, CMV, VZV, HIV1+2 after consent. Genetic tests for 17p deletion, TP53 mutation, and IGHV mutation status. Urine pregnancy test. ECG plus or minus echo if clinically indicated. Record performance status, ECOG. Consent and counseling. Fertility: it is very important the patient understand the potential risk of infertility. Consider dental assessment/advised dental check is carried out by patient's own dental practitioner before treatment starts. Assess the level of risk of tumor lysis syndrome, TLS, and provide prophylactic hydration and therapy accordingly. For patients at high risk of developing infusion-related reactions, IRRs, to obinutuzumab, consider prephase dexamethasone. Dose at consultant discretion, 4 to 10 mg oral daily for 2 days, starting 48 hours before the first dose of obinutuzumab. Prephase steroids are unlikely to be needed beyond this point. Consider withholding antihypertensive treatments 12 hours before, during and for the first hour after the obinutuzumab infusion. Patients at acute risk of hypertensive crisis should be evaluated for the benefits and risks of withholding their antihypertensive medications. Treatment should be agreed in the relevant MDT. Drug regimen. Cycle 1. Drug. Days. Dose. Route. Administration details. Hydration and pre-medications. Day 1, 2, 8, and 15. Oral and intravenous hydration. Obinutuzumab. Day 1. 100 mg. Intravenous. In 100 ml sodium chloride 0.9%. Over at least 4 hours. Day 2. 900 mg. Intravenous. In 250 ml sodium chloride 0.9%. Day 8 and 15. 1,000 mg. Intravenous. In 250 ml sodium chloride 0.9%. Venetoclax. Day 22 to 28. 20 mg once daily. Oral. Dispensed as 10 mg tablets. Take in the morning with food asterisk. Cycle frequency, every 28 days. Cycle 2. Drug. Days. Dose. Route. Administration details. Hydration and pre-medications. Day 1. Oral and intravenous hydration. Obinutuzumab. Day 1. 1,000 mg. Intravenous. In 250 ml sodium chloride 0.9%. Venetoclax. Day 1 to 7. 50 mg once daily. Oral. Dispensed as 50 mg tablets, 50 mg dose, and 100 mg tablets, 100 mg, 200 mg, and 400 mg doses. Take in the morning with food asterisk. Day 8 to 14. 100 mg once daily. Day 15 to 21. 200 mg once daily. day 22 to 28. 400 milligrams once daily. Cycle frequency, every 28 days. Cycles 3 to 6. Drug. Days. Dose. Route. Administration details. Hydration and pre-medications. Day 1. Oral and intravenous hydration. Obinutuzumab. Day 1. 1,000 milligrams. Intravenous. In 250 milliliters sodium chloride 0.9%. Venetoclax. Day 1 to 28. 400 milligrams once daily. Oral. Dispensed as 100 milligrams tablets. Take in the morning with food asterisk. Cycle frequency, every 28 days. Cycles 7 to 12. Drug. Days. Dose. Route. Administration details. Venetoclax. Day 1 to 28. 400 milligrams once daily. Oral. Dispensed as 100 milligrams tablets. Take in the morning with food asterisk. Cycle frequency, every 28 days. Asterisk see dose modifications below due to venetoclax drug interactions. Patients should avoid consuming grapefruit or grapefruit products, Seville oranges, including marmalade containing Seville oranges, or star fruit within the 3-day period prior to the first venetoclax administration and until the last day of treatment is completed due to possible CYP3A-mediated metabolic interaction. Delayed or missed doses. Obinutuzumab. If a planned dose of obinutuzumab is missed, it should be administered as soon as possible. No doses should be omitted. If toxicity occurs before cycle 1 day 8 or cycle 1 day 15, requiring delay of treatment, these doses should be given after resolution of toxicity and all subsequent visits, and the start of cycle 2 should be shifted to accommodate for the delay in cycle 1. Then original dosing schedule should be maintained for subsequent doses. Venetoclax. Missed venetoclax dose within 8 hours of the time it is usually taken should be taken as soon as possible on the same day. If a dose is missed for more than 8 hours, it should be omitted and the usual dosing schedule resumed the following day. If a patient vomits following dosing, no additional dose should be taken that day. The next prescribed dose should be taken at the usual time the following day. Prevention of infusion-related reactions, IRRs, to obinutuzumab. Risk factors for developing severe IRRs at cycle 1 day 1. High tumor burden. High circulating lymphocyte count, 25x109/L. Renal impairment, CRCL less than 50 milliliters per minute. Both cumulative illness rating scale, CIRS, 6 and CRCL less than 70 milliliters per minute. Infusion rates. Cycle number. Obinutuzumab dose. Infusion rates at cycle 1 and subsequent cycles providing no IRRs with previous obinutuzumab doses. Do not increase infusion rates in case IRRs occur. Cycle 1 day 1. 100 milligrams. Additional risk factors for severe IRRs. Yes. No. 6 milligrams per hour for 1 hour, 12 milligrams per hour for 1 hour then. 24 milligrams per hour until the end of infusion. Total infusion duration, 5 hours 25 minutes. 25 milligrams per hour. Do not increase the infusion rate. Total infusion duration 4 hours. Cycle 1 day 2. 900 milligrams. 50 milligrams per hour for 30 minutes, then increase rate in 50 milligrams per hour increments every 30 minutes to max rate. For 100 milligrams per hour, total infusion duration 4 hours. Cycle 1 day 8 onwards, 1,000 milligrams. 100 milligrams per hour for 30 minutes, then increase rate in 100 milligrams per hour increments every 30 minutes to max rate 400 milligrams per hour, total infusion duration 3 HRS 15 minutes. Prevention of tumor lysis syndrome, TLS. Both obinutuzumab and venetoclax carry the risk of TLS. Debulking with obinutuzumab before starting venetoclax is likely to reduce the TLS risk, Therefore, it is recommended to assess TLS risk before first obinutuzumab dose and reassess after 3 weeks before the first venetoclax dose, adjusting TLS management and monitoring accordingly. TLS risk assessment should include lymph nodes, LN, size, absolute lymphocyte count, ALC, and CRCL, calculated creatinine clearance. Splenomegaly may further increase TLS risk, although this is not part of the formal scoring system. Table 1. TLS risk assessment pre-cycle 1, pre-first obinutuzumab dose. Low tumor burden. Medium tumor burden. High tumor burden. TLS. Risk factors. All LN less than 5 cm baseline. Any LN 5 cm to less than 10 cm baseline. Any LN greater than or equal to 10 cm baseline. TLS. Management. Oral hydration. And allopurinol. Oral or intravenous hydration. And allopurinol. Oral hydration and intravenous hydration and allopurinol and/or. Rasburicase for elevated uric acid greater than 8 mg per deciliter. TLS. Monitoring. Outpatient. Outpatient. Ambulatory care/inpatient. Cycle 1 day 1. Cycle 1 day 2. Cycle 1 day 8. Cycle 1 day 15. Predose. 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 Table 2. TLS risk assessment cycle 1 week 3, pre-first venetoclax dose. Low tumor burden. Medium tumor burden. High tumor burden. TLS. Risk factors. All LN less than 5 cm baseline, and ALC 25x109/L. Pre-venetoclax. Any LN 5 cm to less than 10 cm baseline. Or ALC greater than or equal to 25x109/L. Pre-venetoclax. Any LN greater than or equal to 10 cm baseline. Or any LN greater than or equal to 5 cm baseline and ALC greater than or equal to 25x109/L. Pre-venetoclax. TLS. Management. Oral hydration. And allopurinol. Oral or intravenous hydration. And allopurinol. Oral hydration and intravenous hydration and allopurinol and/or. Rasburicase for elevated uric acid greater than 8 mg per deciliter. TLS. Monitoring. Outpatient. Outpatient. Concurrent medications. TLS. Prophylaxis. Hydration throughout treatment. 2-3L/day oral fluids starting 1 to 2 days before cycle 1 day 1. Medium/high TLS risk, additional intravenous fluids as per table 1 and 2 above. Total oral plus intravenous fluids 3L/M2/day to maintain urine output greater than 100 milliliters per square meter per hour. Allopurinol. 300 milligrams per day starting 2 days before cycle 1 day 1. Reduced dose to 100 milligrams if CRCL, 20 milliliters per minute. Continue for 8 weeks until the end of venetoclax ramp-up dosing. Allopurinol should be omitted on days of rasburicase. Rasburicase. High TLS risk with elevated uric acid, greater than 8 milligrams per deciliter. Consider before first doses of obinutuzumab in cycle 1 and before each first venetoclax escalation. Dose, cycle 1 day 22 and cycle 2 days 1, 8, 15 and 22. Antiviral prophylaxis. Acyclovir, 200 milligrams 3 times a day for duration of treatment and for 3 months after completion. Dose modifications. Obinutuzumab. Modifications are not recommended. In case of IRRs, delay or stop treatment and/or adjust infusion rates as per table below. IRRs grade. Recommendations on infusion rates in case IRRs. Grade 4. Life-threatening. Infusion must be stopped and therapy permanently discontinued. Grade 3. Severe. Infusion must be temporarily stopped and symptoms treated. Upon resolution of symptoms, the infusion can be restarted at no more than half the previous rate, the rate being used at the time that the IRR occurred. If the patient does not experience any IRR symptoms, the infusion rate escalation can resume at the increments and intervals as appropriate for the treatment dose. Cycle 1 day 1 infusion rate may be increased back up to 25 milligrams per hour after 1 hour, but not increased further. If the patient experiences a second occurrence of a grade 3 IRR, the infusion must be stopped and therapy permanently discontinued. Grade 1 to 2, mild to moderate. The infusion rate must be reduced and symptoms treated. Upon resolution of symptoms, the infusion can be restarted at no more than half the previous rate, the rate being used at the time that the IRR occurred. If the patient does not experience any IRR symptoms, the infusion rate escalation can resume at the increments and intervals as appropriate for the treatment dose. The day 1, cycle 1, infusion rate may be increased back up to 25 milligrams per hour after 1 hour, but not increased further. Renal impairment asterisk. CRCL greater than or equal to 30 milliliters per minute. No dose adjustment required. CRCL less than 30 milliliters per minute. No data. In current practice, dose adjustment is not recommended. Hepatic impairment. No data. No need for dose adjustment is expected. Venetoclax. Hematological toxicities. Grade 3 or 4 neutropenia, ANC 1X109/L. With infection or fever, or Grade 4 hematological toxicities except lymphopenia, e.g., ANC 0.5X109/L. or PLT 25X109/L. First occurrence. Interrupt venetoclax. To reduce the infection risks associated with neutropenia, granulocyte colony stimulating factor, GCSF, may be administered with venetoclax if clinically indicated. Once the toxicity has been resolved to grade 1 or baseline level, venetoclax therapy may be resumed at the same dose. Second and subsequent occurrence. Interrupt venetoclax. Consider using GCSF as clinically indicated. Follow dose reduction guidelines in table below when resuming treatment with venetoclax after resolution. Additional dose reductions may occur at the consultant discretion. Non-hematological toxicities. Tumor lysis syndrome, blood chemistry changes or symptoms. Suggestive of TLS. Any occurrence. Withhold the next day's dose. If resolved within 24 to 48 hours of last dose, resume at the same dose. For any blood chemistry changes requiring more than 48 hours to resolve, resume at a reduced dose, see table below, and discuss with consultant. If rapid dose escalation is required due to progressive disease, patients must be admitted for intravenous hydration and management of TLS. For any events of clinical TLS, resume at a reduced dose following resolution. See table below. Grade 3 or 4. Non-hematologic toxicities. First occurrence. Interrupt venetoclax. Once the toxicity has been resolved to grade 1 or baseline level, venetoclax therapy may be resumed at the same dose. No modification is required. Second and subsequent occurrences. Interrupt venetoclax. Follow dose reduction guidelines in table below when resuming treatment with venetoclax after resolution. Drug interactions asterisk. Renal impairment asterisk. CRCL greater than or equal to 30 milliliters per minute. No dose adjustment required. CRCL less than 30 milliliters per minute or dialysis. No information available. Clinical decision. Hepatic impairment. Mild moderate, child PUAB. No dose adjustment required. Patients with moderate impairment should be closely monitored for toxicity. Severe, child PUC. Reduce dose by 50%. Monitor closely. Asterisk consider increased risk of TLS in patients with CRCL less than 80 milliliters per minute. At discretion of the treating consultant, more intensive TLS prophylaxis and increased TLS monitoring may be recommended. Venetoclax dose modifications for toxicity. Dose at interruption. 400 milligrams. 300 milligrams. 200 milligrams. 100 milligrams. 50 milligrams. 20 milligrams. Dose at restarting. 300 milligrams. 200 milligrams. 100 milligrams. 50 milligrams. 20 milligrams. 10 milligrams. Continue the reduced dose for 1 week before increasing the dose. Investigations. Weekly during titration phase, then reduce as appropriate. FBC. TLS bloods as per Table 1 and 2 above, including creatinine and UANEUS, uric acid, potassium, phosphate, and calcium. Liver function tests. Glucose. Restaging. Clinical response should be assessed monthly for the first 3 months. Reimage at approximately 3 and 12 months on treatment as per consultant discretion. Contraindications. Renal failure or other significant comorbidities that increase the risk of TLS. Patients should be treated in centers with experience in managing TLS. Concomitant use of strong CYP3A inhibitors at initiation and during the venetoclax dose titration phase. Extravasation risk. Obinutuzumab, neutral venetoclax, oral not applicable. Warnings and special precautions. MHRA advice for healthcare professionals. Venetoclax. TLS risk must be assessed based on multiple factors, including tumor burden, comorbidities, particularly reduced renal function, and splenomegaly. For all patients, it is important to strictly adhere to the dose titration schedule and to the measures to minimize the risk of TLS. Patients should be advised to stop taking venetoclax and seek medical attention immediately if any of the symptoms of TLS occur: fever or chills, nausea or vomiting, confusion, feeling short of breath, irregular heartbeat, dark or cloudy urine, feeling unusually tired, muscle pain or uncomfortable joints, fits or seizures, abdominal pain and distension. Adverse effects/regimen-specific complications. Venetoclax, obinutuzumab. The most common grade 3 and 4 adverse events in the phase 3 trial included neutropenia, 52%, thrombocytopenia, 13%, infections, 17.5%. The most common grade 3 and 4 adverse events in the phase 3 trial included neutropenia, 52%, thrombocytopenia, 13%, infections, 17.5%. Other common adverse events reported include greater than or equal to 10% anemia, 16%, IRRs, 44%, diarrhea, 27%, nausea, 18%, pyrexia, 22%, fatigue, 15%, cough, 16%. Infusion-related reactions, IRRs. Rashes, allergic and anaphylactic reactions or cytokine release syndrome, dyspnea, bronchospasm, and hypoxia, in addition to fever, chills, rigors, urticaria, and angioedema. Treatment-related mortality. Less than 1%. Exclusions to treatment. Age greater than 80 years or significant frailty. Creatinine clearance, CRCL, less than 30 milliliters per minute or dependence on dialysis. Clinically significant cardiac impairment. G6PD deficiency. Comorbid conditions needing careful fluid management, e.g., diabetes insipidus. Drug interactions unavoidable, having potential to need careful adjustment and monitoring of medications for other comorbid conditions. Consult pharmacist. Expected poor compliance with treatment directions/monitoring requirements. Thank you.